I'm really excited to be here. I think of myself really just as a family doctor, a regular family doctor, and since I stepped into this position a year ago, there's been quite a bit of being in very technical scientific symposiums which tend to lack a sense of humor, and meetings with ambassadors, the Israeli embassy, the Sudanese embassy, not funny places. So it's just, I'm excited to be here. I'm thrilled there's so many. I understand there's other rooms filled with people as well. I also understand the advantage of the other rooms is you get to eat and crinkle your wrappers while people are talking. But so thanks so much for getting up this early on the weekend. I don't know how normal that is for many of you, but for me it's not. So I'm going to talk. Some of what I'm going to say is heavy stuff. It's intentional. I get feedback. It's too serious, but I really want there to be things for you to think about and chew on. This thing that Lauren said, that it's more than medical school to be a physician, I think that's really, really true. And there's no time like now. I think many of you are already thinking about that, about your communities, about where you come from, about where you want to go. And so I want to give you some more stuff to really kind of chew on and get into. I just advance notice, I'm very sorry, I have to leave around noon today, but there's going to be time between this and then, so that if you have questions, if you have ideas, if you have challenges, thoughts about what I say or anything you want to bring up, please find me and grab me and come talk to me. So in early summer 2007, one of our Doctors Without Borders physicians who was working to oversee our HIV care in Kampong Cham, Cambodia. This is 3-4 hours outside the capital, and she'd been there about 8 or 9 months already, and she did her morning clinic, seeing patient after patient with really high quality care, triple therapy, ARVs being used, really an excellent program, managing HIV and TB co-infections. And she came out of the space in the side of the hospital where our program had been working, and she came around the corner, and she noticed that outside of the pediatric ward there were about a dozen beds, small pediatric-sized beds, outside the ward in the sort of walkway and then spilling down the kind of front concrete entrance of this part of the hospital. And had obviously never seen that before. It's not that normal to house people in the courtyard. So what this was the result of dengue. And dengue it's a mosquito-transmitted virus that can lead very easily, especially in children, to shock, hemorrhage, and death. Children are the most vulnerable, the most susceptible to this. And dengue, though we don't really talk that much about it, is actually one of the diseases that's continuing to increase in the world, increase in its geographic scope, in the countries it's in, going from cities out into rural areas, increasing in frequency. Epidemics that used to come every so often and then every 5 years are now coming as often as every 3 years. And the mortality is increasing as well, despite the spread of knowledge and guidelines for how to manage the disease. And this is a disease that continues to increase. Dengue can be really subtle clinically, but is also really devastating. The first day I was there, and I went with this emergency team to try to help the hospital, to try to aid their response. There was a small boy kind of in triage brought by his mother, and you take a history and you question the mother, and she explained that the fever that had been going on for about a week had finally gone. His vital signs were normal. And you do your exam, right? You start with the head and the eyes and the ears and the nose. And then you open the mouth, and just everything else looked fine. And you open the mouth, and you can see there's just a little bit of bleeding from the gums inside. And this is some of the first sign of the possibility of hemorrhagic dengue. And with a child like that, 12 or 24 hours later, for lack of a simple intravenous infusion or a blood transfusion, that boy's going to be dead. So we set about with this hospital, which continued to increase. There were more and more beds outside, 3 to 4 times the normal capacity of the pediatric ward. So they opened up storage rooms, put people in there. You know, we brought a doctor to manage the intensive care area for the very sickest, to establish 24-hour coverage of the hospital, nurses to do triage and surveillance, training of student nurses, which was the only resource we had to build the staff inside the hospital. Managing IVs, a logistics specialist to the water supply necessary, the sanitation to run a hospital service, to get supplies there, to deliver the medical materials, bring in international orders, to a hospital and a hospital system that's completely overwhelmed by this kind of thing. The summary really is, that what we try to do is we try to target the sickest, the most at risk, the most vulnerable. You want to deliver direct medical care and work to prevent the death of specific patients, and that this is not the last time. This coming year, 2010, we expect another epidemic. The conditions, the situation is not any better, the prevention is not more, and the people there are not any safer than they were just a couple of years ago. The needs really that are out there are immense, and we need to recognize those needs, and then to respond, that we make a choice to be there and to meet the needs with our actions. I want to talk just a little bit about Doctors Without Borders, or Médecins Sans Frontières, or MSF as we're known internationally. So MSF is an international, independent, medical, humanitarian organization. And this is a very specific thing to our mind. Humanitarian, that word is used to apply to almost anything, it feels like these days in the media. Anyone who drops off a basket of food or sends a piece of clothing, everything's called that. But for us, it's really very specific. And there's key concepts in the work we do that I want to explain and put before you. So one is impartiality. And what that means is that there's no discrimination whatsoever in the care that we provide and who we provide it to. That we do a medical triage, that treatment is based on needs and the urgency that those patients have. And so race, religion, creed, political conviction, all of this is separate. We treat people based on the need, the urgency they have. Neutrality. It seems like a little bit of a not necessary thing when we talk here, but in many places, the group you come from, the party you're affiliated with, these things can impede your ability to get care, your ability to get taken care of. And that's an important part of what we do. Independence. It's absolutely important that when we go into the field, we're able to make our own decisions, to make our own assessment of what the needs are and where help needs to go. One pillar of this is our financial independence. We take no U.S. government funding, and we have over 500,000 private donors in this country, from the smallest amounts to large donors, who enable us to have the resources to make the decisions at the moment we need, according to not a political agenda, not in a country that is a friend to this country, but according to where the need is greatest. And the last thing is the freedom to exercise the functions that we do, to act on what we think is correct and what's needed, and not be constrained by local or national or international authorities who would like to gather people together or direct things in a certain way. We aim to meet a population in crisis. It can be an emergency, a traditional emergency that we think about, a tsunami or a war, but also a chronic situation with intense and dire impact on the population, malnutrition, neglected diseases, things like this. Then we go to armed conflict and war, natural or man-made diseases, epidemic disease, population displacement. All of this is the kind of work we want to do. The bulk of it is in Africa. The degree of conflict that we find in several countries there, in DRC, in, again, South Sudan, in Somalia, Central African Republic, but we also work in Pakistan now for the displaced populations, and after the earthquakes there a couple of years ago, in the Palestinian territories, in Haiti, in Sri Lanka, and Burma. We work in total in over 69 countries around the world, and there's 27,000 people just right now who are doing that work. It's not all people like me who leave here to go away. More than 90% of the people doing that work come from those societies, from those countries, to step forward and carry out this important work that we do. So the humanitarian act, like I said this before, is really specific. It's a human-to-human action. And what it is to say that this particular patient has to be treated now, and that we will go to where this is, and the patient who's there must be cared for. Humanitarians, though, are not other people. It's not some kind of strange and other category. And MSF is really a movement. It's members of civil society who come together around a common purpose. At our core, we're all doctors in the movement whose fundamental principles, and really just what are basic medical ethics, are thrown into relief by the crises we seek to work in and the sometimes really severe challenges to that work. So I want to talk to you about two contexts that we've been dealing a lot with recently and that are really in our minds right now. So the first of these is the situation in Afghanistan. We are just in the process now of returning to our work there. We had been in Afghanistan for about 27 years until 2004, where 5 of our staff were murdered in their activities, in their work there. We're going back now because there are people who are talking about Afghanistan in need of development, in need of education, in need of country building, but there's a war going on there. In large parts of the country, most people have no access to medical care at all, even the most basic primary care services. And the population, they're in an incredibly vulnerable position, especially in areas in the south where the conflict is the most intense. So actually this month, just outside Kabul, where there are literally millions of displaced people who have come back to the country, mostly out of Pakistan just recently, and in Helmand province in the south, really at the heart of the conflict, we're going to be opening 2 hospital programs with including full access to surgical services, obstetric care, a full range of hospital services. The idea, again, is that the needs there, the situation of the population, are so intense that we need to be back there and to go. We go, though, not without really serious difficulties and serious challenges to the work that we do. I think some people may have heard of the bombing in Kunduz, where a tanker was hit by coalition forces and exploded and killed, in the end, probably dozens, maybe up to 100 civilians. And that seems to have made the news, and that mistake or that error, whatever it was, is deplorable. There's other things, though, that you really haven't heard about. So in August 26th, so just a little more than a month ago, in Paktika in Afghanistan, after there was a firefight, there was a Taliban commander that was removed and injured and went to a hospital facility to be treated. Afghan national forces surrounded the hospital. They were fired upon not from the health facility but from a nearby building. They fired back to all things in the area, including the hospital. They called in airstrikes from American forces, who then bombed the hospital. The hospital was stormed, the Taliban commander was arrested, and the hospital was largely destroyed. That Taliban person, as well as others, were forcibly removed from the hospital. Just a little more than a week later, so on September 2nd, in Wardak in south central Afghanistan, there was another incident. This time with another NGO working there, a Swedish organization, and around 10 o'clock at night, coalition forces, including American forces, stormed the hospital, searched the entire thing, breaking down rooms, tied staff members and family members up while they're in the hospital, and spent 2 hours there investigating, and left with a warning that if anyone who comes to the hospital that there's suspicion of there being an insurgent, that the forces are to be notified first, and that only then will the military commanders decide who can and can't be treated. We don't hear about this in the media. these are basic fundamental principles being violated. The respect, and this is written into international humanitarian law that our country and most countries have agreed to and signed for more than 50 years, that there should be respect for medical personnel and medical facilities in the field. These are protected persons and protected facilities, no matter what the conflict or who is there, that these are to be respected and not to be harmed. And also the protection of individual patients, their confidentiality in their person, no matter who they are or who they're with. When they're a patient in a hospital, when they're sick, until they're discharged, until they are leaving, they're a protected person under international law. And these have been gross violations. To try to defend these principles, we speak here, we speak in the field as well. We speak with all parties of the conflict. That includes local warlords, Taliban, Afghan government and security, U.S. government and military, all the parties to the conflict. The bottom line, even to go just a bit further, one of the even more than this, the provision of aid, generally speaking, it used to be something kind of a side project. Militaries would be in the field. While they were there, they would do some reconstruction, leave some supplies. But it's really grown to the point now where the provision of aid is now a major component of military strategy for many forces. And what this does is it instrumentalizes the aid, it confuses it. And not only is this kind of aid, which is driven partly by military and political agendas, not likely to help or to reach those most in need, but the confusion between often contractors for these groups and what they look like and the tools they use and the habits they have look more and more like aid workers and humanitarian workers in the field. This increases the risk to our teams just for their sheer safety, and it sows confusion in the population and undermines the trust and relation we have with local authorities and the communities that we're working in, which is the only way we can work in places like this safely. In general, what we do when there are needs like this, we choose to go. We want to raise our voices. We want to raise our voices that humanitarian law be followed and that there's a space for us to work, not primarily for our own safety, but so that the population that's there can be helped, that we can reach them and get there to meet the needs that they have. There's a second a different kind of crisis I want to talk to you about, and that's Chagas disease. So this is the 100th anniversary of kind of an amazing scientific achievement. Dr. Chagas, who described the organism, the vector, the clinical disease all in one. It was sort of he's the triple threat of scientific medicine. And that's a feat in medicine that actually hasn't been duplicated since that time. So Chagas disease, it's due to a parasite. It's closely related to human African trypanosomiasis, or sleeping sickness. It's transmitted by the vinchuca bug, which lives in the thatch or adobe homes of typically the poorest people in rural Latin America. Once infected, and this is often children, the disease enters primarily the heart and other smooth muscle and silently replicates over some 10 to 30 years. About a third of those people will die from the disease. And it's usually in the form of a really malignant form of heart failure, a huge, floppy, dilated heart that either can't pump enough to keep the person alive or just has a series of electrical abnormalities, and there's a very high rate of sudden death in this population. Chagas disease is one of what we call the most neglected diseases. As I talk about it in different places, I almost always get these kind of quizzical looks or blank faces, and that includes people in the medical field. I don't know how many of you had heard of it before or now. Oh, okay, much better. That's far better, actually, than meetings of residents. It's far better than general population. You're way ahead of the game, actually. But there's a few things currently. So despite 100 years ago, we knew about as much as we could have known about the disease at that time. There's still no test of cure. There's no way, actually, to know once you've given treatment to someone, there's no way to tell them whether they're cured or not cured if they still have the disease or they don't. There's absolutely no way to know. And without this, to do good research, to do good clinical care, it's virtually impossible. There are indicators, there are other proxies, ways you can try to get that, but to have that simple thing that we have, it severely hampers research and our ability to take care of patients. Also, we need really safe and effective drugs. There are 2 drugs now that are used. They're nifurtimox and benznidazole. Neither one of them are approved for use in this country. And they're decades old, some 40, 50 years old, with very high rates of side effects. There are no formulations for children, so for the treatment of children, tablets have to be cut usually into 4, 5, 6, 7 small pieces. You can imagine what that does to correct dosing and the ability to treat. And the pipeline, the research pipeline for development of drugs is practically empty. There's nothing other than a handful of molecules that really haven't left even the basic research lab. The main impediment, though, even beyond those, is simply access. Access that a patient infected with a disease would be able, that they should be able to be diagnosed and be able to receive treatment, at least to cure or slow the disease. So right now, this is not a small problem. In Bolivia, there are 1 million people who are infected with the disease. This is 1 in 9 people of the entire population of the country. And outside the MSF program we have in Cochabamba there, which has now treated some 3,000 people, a fraction really of the ones who need it, but very few are being treated in anywhere else, and primary care doctors there refuse to engage and treat patients. In Mexico, there are another 1 million people infected, and there's no program for diagnosis or treatment at all in that country. 3 times in the last couple of years, a large supply of medicine to treat the disease arrived in customs in Mexico, sat there, and was eventually returned from the donors it came from, because there was no one who could take it up, and there was nowhere for that medicine to be used, and no political will to bring it in the country and to make sure that it gets to patients. In the U.S., as well, there's 300,000 people infected with this disease, and there's no drugs approved for use, as I said, in this country. And a total of 45 patients in the last couple of years that have been treated under a compassionate use, which is possible but a really laborious process of a doctor having to fill out paperwork and get medicine directly from the CDC for that individual patient. So out of the 300,000 in this country, about 45 have been treated, and half of those by Drs. Maimondi and Drs. Traina at Olive View, the LA County hospital connected with UCLA. So I just came from what we were doing the last couple of days is holding a public event and then one of these technical symposiums to bring together key stakeholders, key people, policymakers, scientists, researchers, clinicians in this, to bring them together to put together some call to action, a clear thing about how we're going to go forward. And we heard, at this public event, people came out of the audience, we didn't expect this at all. But we had one woman spoke to us, Mayra Gutierrez. She's 33 years old, a native of El Salvador, and who was diagnosed really by chance. She gave blood at a Red Cross blood drive in 1997. It just happened to be during the time where the Red Cross was doing a little exploring, a little sort of testing the blood supply, just to see if there was Chagas in the blood supply. She got a letter, and so she just happened to give during that window. She got a letter that said, you have Chagas disease, and really nothing else, no other information. Please call this number. She called the number. She was given, she said, even more vague information, and was told that there was no treatment and that there was no one she could see to take care of this disease, but that it would be a good idea for her to see her doctor. And so, and she just described to us, this 11-year And in the audience, just sort of just to sort of emphasize the point, and someone that we had not met before, a 61-year-old Bolivian woman stood up at the microphone, the first person to speak, and described that her repeated esophageal surgeries, that essentially they'd taken out a piece after piece, so there's practically nothing left. Also, esophagus with the smooth muscle that needs to function. And she had been told that she had 2 areas of her heart that were already damaged and not working well, and she had had regular care at UCLA, at that same institution, although a different part of it. And she'd been in the U.S. for 40 years, and no one had ever offered her treatment. So the point is, again, so there's an urgency before us. Chagas is only one example, but it's an important one. There's a total of 15 million infected people in the world, and it kills some 14,000 people every year, this year as well. And we have to break the silence about it. We have to raise our voices, talk about it to friends, family, to your own community, and to get treatment. The time to treat is now. There are many limitations to that treatment and ways in which it's difficult, but the time is now to start. And so again, this is to see the needs that are just nearby and just around you or connected to who you are in your community. To see these needs, to bear witness to those needs and the suffering that goes on in it, to speak up and to speak out, to choose to act. This is really the thing. What characterizes, I think, the work of a physician, the good work like this, is what we call kind of an ethics of refusal. And that's a refusing to accept the way it is, the way it has been, or what others have accepted, to refuse to abandon or sacrifice the lives of our neighbors, our community, and others in our human society. So what I've been describing applies, these principles and the challenges we have apply just as much here at home as it does far away. Jubin described a little bit of where I've been working, but before Cambodia, there was Kampa, Central Tibet, and Sierra Leone, but there's also been working with Gulf War vets in Pennsylvania, immigrant, homeless, the mentally ill of the Tenderloin in San Francisco, asylum seekers detained in warehouses in Queens, New York, in San Quentin State Prison. When MSF speaks, it's always from direct knowledge and direct working with patients, so I speak now personally about my experience here in the U.S., not for MSF, but as a family doctor, an American physician. These needs here at home are really many, and they need to be responded to. The mental and physical trauma of veterans coming back, the treatment for substance abuse, barriers of culture and language and poverty in this country, the exclusion and fear of undocumented people in our society. The entire California state prison health system, they lost, after losing one legal action after another, for inadequate health care, for inadequate mental health care, inadequate transport to care, even simply getting one patient from their cell to a doctor in the same institution. And after a whole series of these, the entire California prison health system is now in receivership, which means a federal judge is appointed to take charge of the entire system to try finally to get some change to make something better. And that's going to continue until the quality and that access to care is improved. We have to see what's around us and choose to act. This ethics of refusal, and again I'm speaking as an individual here, but to refuse to accept that in health, in medical care in this country, the poor get worse care than other people, that doctors don't speak the language of our patients, that the addict is condemned or refused, and that the homeless are not brought inside the walls of the office. We should refuse to accept that of the 300,000 people infected with Chagas disease in this country, that no matter what scientific and regulatory and clinical progress is made, many of them will still have difficulty to access treatment because in order to pass health care reform, our leaders have promised to exclude millions of people from this care. Ultimately, we should seek to be with and treat all patients correctly and respect and ensure the dignity of the patients wherever and whoever they are. So well, I told you it was going to be a bit heavy. I want to just, I want to not end there for sure. So I want to just talk a little bit about your path to medicine. I completely agree and respect with what Lauren said about not trusting any of us, so take that for sure. I just really quickly, so, I mean, as opposed, it sounds, Lauren started at 4 years old. I think I started wanting to be a doctor about 4 or 5 years after I finished medical school. So, you know, I was actually, I was a philosophy major in college, which doesn't indicate a real sense of direction. But it definitely is not this early in the morning. But why I did go to medical school in the first place was some sense that I wanted to kind of reach out and reach across to be able to encounter and understand others, the other human beings, other communities, and I wanted to do it in a way that there was really something concrete, that I had something to do with my hands, that I really wanted to have something to offer. And it wasn't direct. I didn't know really what that was. I had applied to medical school. I deferred for a year. I lived in a basement with 5 other people in New York trying to figure out what I wanted to do. And this path was not directed at all. There was temping in offices. There was a failed attempt at the music business. There was very worse attempts at writing. And then eventually, I went and I traveled for a few months, and then sort of showed up in medical school. So this, that it's true. I mean, but I think it's part of what Lauren was talking about the path, and to make your own choices and to find your own way. I think that's really important. It's hard for sure. I don't want, biochemistry. I don't know what to tell you, honestly. I got to medical school, there were 3 or 4 people that had taught biochemistry already who just thought they would, take it again their first year just for fun. Is anyone here teaching biochemistry? I want to talk to you afterwards about being nice to everyone else. All right, well, you're hiding, but okay. But anyway, it's long and it's hard, it's for sure, and don't believe for sure anyone who tells you otherwise. But it really is, it's possible and this is something that can be achieved. Many others have done it, and you can do it as well. Ask for help. Turn to those around you, your friends, your colleagues who become friends, the people who have gone before you. Find a mentor or more than one mentor. Make them pay attention, listen to you, and help you. Your parents, your elders, all these people. And make sure that people come and help you in this process. All along, as you go through, keep with you your sense of what's important to you. Keep your eye on that goal, even when the education and the training at times seems very, very far away from that purpose. And I have biochemistry in mind as one of those things very far away. At every juncture, at each point, really follow your curiosity about things, respect your loves and your passions, and and do the things that serve that. The walls of our institutions are really artificial, and the limits of our specialties in American medicine they can be arbitrary. Determine what you do by the needs that you see there and around you and what you're moved by. And MD it's an incredible degree. It has incredible flexibility and possibilities. It's not a path that gets narrower and narrower, and you shouldn't look at that way. If people explain to you that there's a certain way of doing things, this is the thing really not to believe. This degree, it garners respect around the world wherever you go. To be a doctor is to have capability. You can make a personal choice. You make this personal choice to this path to study and train, but how you do it and what you choose to do with it can be political and powerful. It's also an amazing gift to be a doctor. People will listen to you, they'll talk to you, they'll open their lives, their communities, they'll share with you, and they'll invite you in. And I'm over and over again really moved and transformed and incredibly grateful to be in that place. To be with others, to honor their dignity, to see them and hear them, to be aware of need and to choose to act, to speak out. These are the opportunities that lie before you. We need you, what you bring, and what you will do, and we're eagerly waiting for you. Thank you.